Community Assessment, Raleigh, North Carolina, Suicide in the School-Age Population by Catherine Bauer, Bethany Gallagher, Christina Lee, and Christopher Parnell. The Windshield Survey revealed that Raleigh is North Carolina's state capital. It is defined by major highways and interstates that circle the core of the city. Main roads dissect the city and connect smaller communities within Raleigh. Communities are identified by geographical locations such as north, south, downtown, and east or west. The city has a mixture of older homes, newer built homes, and newer style apartments, commonly called subdivisions. Healthcare centers include hospitals, urgent cares, dental offices, and private physician offices. They were easily located by signs throughout Raleigh. They were easily accessible by public, either by foot or by transportation, as well as via ambulance. Physician offices were easily visible from the roads by the provider signs on their buildings. Mental health and substance abuse facilities were limited. Based on the 2010 U.S. Census, Raleigh's population was 403,829 individuals. We have the second largest population in North Carolina, with Charlotte being the first. 48.3% are male, 51.7% are female, and 23.1% are under the age of 18. The demographics are as follows. 57.5% are white, 29.3% are African American, 4.3% are Asian, 0.49% are American Indian or Alaska Native, 0.04% are Native Hawaiian or Pacific Islander, and 5.6% are other. 2.6% identified by two or more. Raleigh's population consists mainly of Caucasian individuals. Raleigh is a culturally diverse community. Small businesses and markets were present in which offered foods and products included Korean, Hispanic, and American styles. Advertising was present for varying small festivals specific to certain cultures. Festivals included cultural-specific food, clothing, and games. Parks, greenways, and lakes were busy with a diverse population. Fishing, walking, swimming, exercising, and organized sports were seen. Social services were difficult to find outside of the downtown Raleigh area. Homeless shelters, social services, and protective services were more accessible in downtown Raleigh. The Raleigh Public School System is a part of the Wake County Public School System. According to Wake County, with 159,549 students during the 2016 to 2017 school year, Wake County is the largest school system in North Carolina and the 15th largest in the U.S. The demographics of the school system are similar to that of the city. School systems are spread throughout the community and they are large in size. School systems consist of private and public schools with elementary, middle, and high schools. Some schools had trailers or mobile homes within the school property, which identified as extensions of the classrooms. All schools located within Raleigh appear to be in safe condition regardless of the year built. For example, Broughton High School is located in downtown and has a historic appearance. The school-age population appears to be diverse from an outside perspective. Some safety concerns with the school systems include lack of crossing guards on school grounds, adolescents driving erratically and at dangerous speeds, driver safety and the safety of young children leaving school grounds via foot. For example, Broughton High School is surrounded by local fast food restaurants, bars, and shopping centers, leading to children crossing busy traffic areas. Many children were seen running throughout shopping centers unsafely and not using designated crosswalks. School-aged children were seen smoking cigarettes behind stores near the school, and children were seen fighting in a nearby neighborhood located in close proximity to the school. Another concern would be lack of security in areas with school-aged children. No police were present when school was released to deter strangers from unsafe interactions with children. Fire stations were in close proximity to most of the public schools. Youth and young adults have the highest rate of self-inflicted injury, hospitalizations, and emergency department visits of all age groups in North Carolina. Among ages 10 to 24, there were 422 suicides, indicating 7.2 per 100,000. There were 5,167 self-inflicted injury hospitalizations from 2009 to 2011, and there were 13,331 ED visits for self-inflicted injury from 2009 to 2012. Youth suicide is 17% higher than the national average and the second leading cause of death in ages 15 to 34. The North Carolina Youth Risk Behavior Survey is an anonymous questionnaire given to middle and high school students every other year, and it indicates about 20% of students have seriously considered suicide. From 1988 to 2002 in North Carolina, white individuals between the ages of 10 to 24 experienced more deaths from suicide than minorities of the same age. The suicide rate per 100,000 for whites is 17.2%, with American Indians being at 12.4%, African Americans at 5.4%, and Asians and Pacific Islanders at 5.3%. The suicide methods include firearms, suffocation, and poisoning, with prescription drugs accounting for the majority of suicide poisonings. Suicide rates often vary by gender, age, and other demographics, but females attempt more frequently than males. However, males are 3.7 times more likely to actually accomplish suicide. Our primary intervention for suicide would be to include suicide prevention education in the teaching curriculum for the Wake County Public School System. 1 in every 3 school districts nationwide does not require teaching about suicide, and almost 1/2 of all schools do not teach about suicide prevention. School professionals may fear that teaching about suicide prevention can provide students with ideas and methods about killing themselves, leading to increased suicide attempts. However, research proves that when issues concerning suicide are taught in a sensitive and educational manner, students show significant gains in knowledge about suicidal warning signs and more positive attitudes towards help-seeking behaviors with troubled peers. Our secondary intervention would be to assess students for suicide risk and ensure that students receive appropriate care. Schools should determine whether emergency or short-term procedures need to be followed and whether long-term services need to be arranged. They can have specific protocols in place within the school system that can be activated if a student is assessed as a positive risk. The school should contact a child protection agency or community mental health agency for assistance. Our tertiary intervention is a school suicide postvention. That refers to school activities that occur after a student has threatened, attempted, or completed suicide. The goal of a postvention is to minimize the trauma to students and reduce the likelihood of copycat or further suicides. When suicide occurs, it is a traumatic event for many survivors, and suicide clusters are well established among adolescents, so the school can respond to an actual suicide, and that response is crucial. Steps should include responding promptly after the event, within 24 hours, acting in a concerned and conservative manner, informing all staff and school board members of the even and action steps, having teachers announce the death of the student to their first class of the day, making counseling sites available throughout the school, avoiding any glorification of the suicide, assigning a school liaison to handle media inquiries, and monitoring the school's ongoing emotional climate. Nursing diagnosis for this issue include risk for self-directed violence, risk for suicide, risk for poisoning, risk for self-mutilation, hopelessness, risk for situational low self-esteem, ineffective coping, risk for injury, and ineffective impulse control. We did a key stakeholder interview with Jane Miller and Susan Robinson. They are members of the North Carolina Department of Health and Human Services Division of Public Health in the Injury and Violence Prevention Branch. Their aim is to provide education, technical assistance, and data surveillance statewide, but do not provide direct clinical services. Jane Miller reported that Wake County school systems do have a suicide prevention program in place, and that includes educational programs for the staff and students, including implementation of suicide prevention interventions. Nationally, all suicide-related calls can be directed to the National Lifeline, and locally, the Raleigh Hope Line provides local crisis phone support and offers a texting option. These are some local and national resources for suicide prevention. These resources are encouraged to be distributed to any adolescent considering suicide. Some of them are local, such as the Raleigh Hope Line, Holly Hill, and the UNC Crisis and Assessment Center, whereas the National Suicide Hotline is a national resource. Take 5. You're worth it. To those of you who feel utterly hopeless, overwhelmed, think there is no way out, or see nothing to look forward to, I ask you to take a few minutes to consider another possible solution than that of ending your own life. Community strengths and abilities of Raleigh, North Carolina include availability of parks, green spaces, recreational areas, and medical services. They also include a large, diverse population and an established, well-trained school system employees. Weaknesses include lack of enough mental health care providers to serve adolescents in a timely, cost-effective manner, unsafe drivers, especially around school-aged children and school buses. Youth suicide is 17% higher than the national average and is the second leading cause of death in ages 15 to 34, and the third leading cause of death in ages 10 to 14. On average, 2 Wake County school students every year die by committing suicide. These are our references, available if anyone would like to see them more in depth. Thank you very much.